Good day and welcome to this 2011 McKesson EHR webinar series, Coding Compliance, Getting Paid Under Upcoming Regulations. During today's conference, you will have the opportunity to ask questions by pressing star 1. Please be aware that you will be prompted to record your first and last name at that time, and that the recording will be played into the conference prior to your line being open to ask your question. At this time, I'd like to introduce Lisa Santos with McKesson. Please go ahead.
Thank you, Tellery. I just want to first thank everybody for joining the call today. We're here to discuss some very important and imminent topics on ANSI 5010 and ICD-10. As the moderator mentioned, I'm Lisa Santos with McKesson, part of the marketing department, and we're very pleased to bring to you two industry experts on the topic at hand today, Ron Sterling and Betsy Nicoletti. Just before we get started and before I pass it off to Ron here, a couple housekeeping items. We will be recording the webinar today, making it available as well as the slides to all of the registrants. So you'll see an email come within the next day or so with that information. And today's content will probably run about an hour in length, and then we will be opening it to questions at the end, as the moderator had said. I do ask that if anybody has specific product questions, so questions around McKesson's EHR practice management solutions, we'd love to address those offline just so we can use Betsy and Ronald's time to the max here. But we will have an email at the end we'll present. It's practicepartnerinfo@mckesson.com where you can send any sort of questions, and we'll make sure we get those to the appropriate individuals within McKesson and get them answered for you. And then before we get started here, quick introductions. Ron Sterling is going to kick it off for us today. He is a CPA. He's been around the business for a number of years in practice management consulting, and is also now focusing on the EHR piece of the business as well. So you may have seen him with some presentations around within the industry. He's going to take us through all of the ANSI 5010 information today. And then following Ron, we will have Betsy Nicoletti, who's co-founder of Codepedia.com, which is a wiki about coding. And she has also written several books and led many presentations on the topic at hand. She's our ICD-10 guru, and is going to start talking to you about things your practice can do now for ICD-10 regulations of October 2013. So with that said, I think I will pass it off to Ron.
Thank you, Lisa. Good afternoon, everyone. We're going to talk about the 5010 release of the 837 and the other claim formats from the HIPAA transaction set. I think the first thing to understand is that the HIPAA transaction set actually represents an entire life cycle, and the 5010 updates have been established for a number of these different transactions. There's an eligibility request. We have an eligibility response that allows us to know whether the insurance company is covering our patient's services. We have a very interesting transaction called the service review request, which actually deals with authorizations. And then we have the 837 claim, which is going to be the focus of our discussion today. There's also been some changes made to the 835 payment advice, which is our electronic explanation of benefits. But those changes are not really things that affect you as much as the changes to the 5010. The 5010, to take a look at some of the life cycle aspects of these different transactions, we have here the health claim status, and we see that we send an 837 claim to a payer, and we can have an exchange of claim status information. A lot of time that's handled through your clearinghouse. And then the 835 payment advice, the electronic EOB, will come back, and that also has some changes in it. And some of the changes that are in the 837 claim under the 5010 version are going to affect our ability, and some of the things are going in on the 835. For example, one of the key issues about a 837 claim is its ability to actually do a crossover, what we call Medicare crossover, but it actually can handle it electronically. In other words, the secondary claim doesn't have to be filed by our practice. In the 5010 environment, we can actually have the secondary claim being sent from the payer to the secondary payer, and that's kind of a really interesting exercise. This is what we commonly know as Medicare crossovers today, but it's actually quite possible with any insurance company to take care of that. Some of the changes of 5010 is that to understand this, remember that the 4010 was created 7-8 years ago, was when we started using it, and it actually goes back almost 15 years to 1996 with the HIPAA Health Insurance Portability and Accountability Act. Since that time, since we started using it back in 2004, there have been a number of issues that have come up, a number of changes that have been needed to the use of the 4010-837 format, and that's basically what's happening. So we moved some information around inside, and that's going to be kind of transparent to you because your practice management software could take care of that if you're using the 5010 version. We have some housekeeping issues that have been taken care of. For example, now we actually require a subscriber number in the insurance information for the patient. Another interesting aspect of the 5010 is the 5010 now says that if you have an insurance company that has a unique number for a patient, Medicare, Medicaid are good examples of this, but we also have some commercial insurance companies that do the same thing. We no longer have to identify the subscriber and the patient. As a matter of fact, patients with unique numbers will actually be identified as a subscriber. And that could be a pretty important change to commercial insurance companies that are using unique identifiers for patients. Also, in addition, the 5010 now says you either have a group number or a group name. You cannot send in both. When you have changes to the format and you have changes to the rules, what happens is people can actually start enforcing these rules. And that can have a big impact on us because if we don't understand what these changes are and we don't understand what the expectation of the payer is, then our claims are going to be rejected, and that's going to delay payment. The 5010 also now accommodates the ICD-10 codes, which Betsy will be talking about shortly. We also have a number of coding issues. A lot of these things are internal things. However, the important thing to note is there are some codes that were available to us in the 4010 that have now been changed or deleted or enhanced in the 5010. For example, we have a number of situations now where we identify coding systems inside the 5010 format, coding systems that were assumed over in the 4010 environment. In addition, things like release of information and attachment types, some of the codes there have been modified. Even the code associated with a patient relationship to the subscriber has been changed. We also have a number of content issues. We now have 4 additional diagnoses. We have some prior authorization and disability information, and there was actually some coordination of benefits claim balancing has now been added to the system. The reason that it becomes important is because as these additional items get added, additional diagnoses and prior authorization information about our cases and whatnot, that information now is available to us and we can communicate with our payers, but if our practice management system is not accommodating those changes or it's not dealing with those changes, that could present some problems to us. The 5010 also is going to result in some workflow changes because we're going to have to change some of the workflow that we have in organizations in order to collect this information, and we're also going to want to make sure that we get that information correctly in the system before we send that information to the payer. There's a number of issues and considerations you need to understand about. First off, remember that the 4010 was based in 1996 Health Insurance Portability and Accountability Act. Prior to the 4010-837, we used to actually have 500 or more different claim formats that we now had to deal with. But in the 5010 environment, we have some updated edits that are required, and some of the examples that we talked about before for changes included that situation, which is a payer information associated with whether a patient has a specific identifier or not. We also have some superseded 4010 codes. In other words, some coding, some codes that we used for various information in the 4010 environment now have changed or been modified in the 5010. And we also are now moving to 9-digit zip codes. Now, the 9-digit zip codes is required for your organization and your practice. The interesting thing about the zip code area is remember that the zip code, the 9-digit zip code, is a 5010 requirement. However, the interesting thing is that the actual need to provide that zip code for a patient has now been modified. In other words, under the 4010 environment, we had to send the patient's city, state, and zip code to the payers. And now, with the 5010, that is no longer required. However, the important issue there is that a payer could require it. The big issue and question would be, and it's going to be payer-specific, is whether the payer, if they do require the zip code, what they will require the 9-digit zip code, which could create some problems for us. But remember, the patient zip code themselves are no longer required in the 5010. It is now an optional item. One of the responses to the change in the format of a claim is sometimes we think that we'll do it through the clearinghouse. As a matter of fact, if we go back to the original introduction of the 4010 claim back in 2004, a number of products actually were sending out original claim formats that may have even been specific to a product, or there was something called the NSF format at the time. There were a number of different formats that were sent out of practice management systems. And we actually sent them to some clearinghouses, and some clearinghouses would actually take the information and reorganize it to create the 4010 claim. When you're trying to fill in the blank in those situations, the clearinghouse cannot necessarily do as much as we may want to do or have as much direct control as we may need from our practice management systems. For example, if we have a code, when we were talking about release of information, some of the release of information codes have changed. If we're using a 4010 code under release of information and we're now trying to create a 5010 claim, the question is what are they going to fill in the blank for release of information? If we go back to the original introduction of the 4010, the release of information is basically our ability, do we have a signed document from the patient authorizing us to submit this information? If we go back to the original 4010, what the clearinghouse actually did was, since most practice management systems at the time did not accommodate that code, the clearinghouse would actually fill in the code and say, yes, they have the information, they have the signed document that they need to submit this claim. There was actually situations where I don't necessarily need it, but the representation was automatically being made by the clearinghouse. We can think of a number of other examples that we might run into problems if we let the clearinghouse make these changes. For example, if we want to take advantage of those 4 additional diagnosis codes to submit our 5010 claim with, well, we can't exactly do it because the 4010 doesn't accommodate us. So the couple factors are the clearinghouse can certainly move some information around, but they're not going to actually be able to deal with some of the more refined items that we need to deal with in our own systems. For example, we talked earlier about how if an insurance company has a patient-specific identifier, they will now be identified as a subscriber, and the patient-specific identifier will be submitted to the insurance company. Well, the clearinghouse isn't going to know that. The clearinghouse is going to go based on the 4010 claim format, which is what we're sending out from our practice management system. So we want to be really careful about what changes the clearinghouse might be making in order to create that 5010 claim if we are using a practice management system that doesn't generate the 5010 claim. So the 4010 is coming out of our practice management system. It is being modified at the clearinghouse level in order to generate a 5010, and they're going to have to make some assumptions. So they can convert the data, but we may not want them to because we are not going to have as much control over what that 5010 claim represents, and it may create some issues for us down the road. The challenges at the clearinghouse level are the clearinghouse can't create any missing information, and also remember that if they're making changes into your claim and they're sending it out as a 5010, those changes are not necessarily going to be reflected in your practice management system. So in other words, if I were to now send out another claim out of the practice management system, that same exact information might be missing, whether it's secondary claim information or resubmissions, and that information could delay the payment of our claim by the secondary payer. Secondly, remember that the clearinghouse is not going to be able to get very specific because literally the information may not be there. When we were talking before about coordination of benefits, they're going to be calculating that information. When we talked before about the information about whether or not you wanted to put in a group name or group number, they're going to be assuming, picking which one would be sent. You're not going to have as much control over it. Also remember that the payers are going to be developing 5010 focused edits. And in order to respond to those edits as we get more information from the payers about what needs to be done, we're going to want to have the control over that within our own organizations. And when we have that situation that the 5010 is now being reflected about what the clearinghouse thought the change was that we needed, we now have no control over it because our practice management system is not generating that 5010 claim. So the importance of the 5010 compliant practice management system is, number one, when we go back and look at these new 5010 practice management system versions, what we're going to notice is that we have improved grouping and organization of the various factors that have to be included in our claims. For example, claim notes. There's an ability to send a note inside the claim. In a lot of cases, that ability was kind of in a place that may have not been very logical, may have been difficult to get to, sometimes was added in the wrong place. So we've seen some dramatic improvements in how the practice management systems are grouping and organizing our information. Remember also that the practice management systems are becoming much smarter about editing the claims before we even send them to the clearinghouse. So we're going to end up with fewer rejections, and I think even the more important part of the fewer rejection aspect is if we get it right within our practice management system the first time, we're not going to have to spend the money or time to come back and rework that specific item. So that's a very big benefit of it. Another issue is that a 5010 compliant practice management system is going to allow you to deal with more explicit handling of this information. So we're going to avoid some of the workarounds that we had to do in the 4010 environment. We're not using as many defaults, and it's just working a lot better within that environment. So, for example, when we're talking about more explicit handling of information, if we now have to promote that patient to subscriber, that's not going to create any kind of problems with us by duplicating the subscriber information in other areas of the system. For example, if we currently have a subscriber that may be the parent, but the patient the parent may be the subscriber, but the patient has their own identifier, we want to send out that claim with the correct patient identifier. We may have to work around 4010 sensitive systems in order to deal with that situation. Some of the strategic issues that we need to consider in the 4010 environment is that the 5010 is due by December 31st, 2011. Right, wrong, or indifferent, this is the position that the payers have taken, not payers, this is the position of the 4010 to 5010 adjustment. And how are we going to make that happen now that we're only 4+ months away from that situation? Remember that we have to we're going to have a response to the 5010 from various parties. Payers are going to, their tolerance for issues may become errors. In other words, if we submit information perhaps early on, maybe some of those codes that are coming out that are not 5010 codes but were 4010 codes will be acceptable. But as payers tighten up that edit, those are going to become errors. There are 7 different levels of edits inside a payer in order to validate a claim. And those edits go from anywhere from validating whether the claim is actually structured according to the 5010 or 4010 format to whether or not the subscriber number is somebody on their rolls. It gets much more granular as they move through the edit process. So in order to respond to payer-specific edits and payer-specific edit checks, you're much better off having direct control over what that claim looks like from your practice management system. It's going to be a little bit more difficult to deal with it over in the clearinghouse. Even if your clearinghouse allows you to go in and actually edit your claims and redrop them and resubmit them from the clearinghouse, that's still not necessarily going to solve your problem because those changes are not going to be reflected in your practice management system. In addition, when we have a 5010 compliant practice management system, we can have more granular claim control so we can adjust the systems, and the practice management system accommodations are now going to focus in on those 5010 claims. And also remember, this is not the end of the road. We're going to have additional changes that are going to occur over time in order to provide us with additional changes to the 5010. And just like we were talking about previously when we were making the point that inside the 837 claim we can do coordination of benefits to send a secondary claim to a secondary payer, all that entire structure is contingent on having a system that allows you to take advantage of that. And quite frankly, in the initial versions of practice management systems that were dealing with the 837 under the original 4010 format, those practice management systems weren't really very good at doing coordination of benefits. So the more benefits that we get out of our system, the more sensitive our system is to the capability of the 837 claims and the more connectivity it has to some of those other claims in the life cycle. For example, we mentioned the 837 electronic explanation of benefits. We mentioned the 270, 271 eligibility. The more connectivity inside our practice management systems in the life cycle of those different claims that are associated with our 837, the more effective it's going to be for your organization to actually deal with it and take advantage of the claims and get paid faster, which is kind of a nice idea. So what are some of the 5010-ready practice management system product issues? Well, one issue not to ignore is the other parallel exercise going on dealing with meaningful use. That your 5010 practice management system products in general are doing a much better job of dealing with the meaningful use demographic capture of information, which is one of the meaningful use core items, and that's an important thing to do. Number two is that you're going to get more effective practice management system use, especially when we're talking about more intuitive workflow to make sure that we dot all our I's and cross all our T's. We mentioned already a number of issues associated with that. We talked about the additional diagnosis codes. We talked about the coordination of benefits. We talked about the information at the patient level dealing with insurance. So all the workarounds that we may be doing right now to deal with those issues in the 4010 environment become a lot better in the 5010 ready practice management systems, mostly because this is an opportunity for the practice management system to be improved to focus more on the 837 claim itself and the 5010 version of it specifically. In addition, we also are going to have improved edits and data entry. In other words, if the practice management system that's 5010 ready now has edits in it that are related to things like disability and some of the other issues that we may be dealing with at the specific claim level, that's going to help us get our information in more effectively on a more effective basis and gather that information up front and rework our workflow to take advantage of that. So what are some of the things that you need to do to make sure that you can implement this? Number one is I think you need to take a look at the 5010 relevant changes. And so you just need to review them and see which ones affect you. Perhaps the disability doesn't affect you at all, but perhaps the patients with their own ID does affect you. Then you're going to have to upgrade your practice management system version to the 5010 version and change your workflow to identify whether there's any changes to information you need to gather a demographic entry or charge entry. And the other thing is to just make sure that you are effectively producing that 5010 claim. A lot of your clearinghouses will allow you to do testing with their systems to verify that you're generating an appropriate 5010 claim. Remember that the 5010 claim itself is something that there's going to be a pretty sudden change on 12/31/2011, and basically it's the payers that can add these edits in that are going to determine how strictly they're going to enforce these changes. Normally what we've seen in the past is we've seen kind of a migration that over time more and more edits go in there, more and more changes go in it, and more importantly, the payers are going to start taking more advantage of this situation. For example, I wouldn't be surprised to see more commercial carriers go to patient-specific ID numbers instead of working underneath a parent. Sometimes there's some confusion on the payer side for a number of different coverage situations that aren't reflected very well when we just know the patient's name and their date of birth. So what is a good readiness checklist for your situation? Well, number one is after you've looked at the 5010, understand what are the changes that are going to be necessary for your organization. And that might be changes to the front desk. It might be changes to your intake sheet. It may be changes to how you deal with payers. You really want to check with your clearinghouse, see what your clearinghouse situation is with 5010. If you're going to stick with a 4010 product, make sure you clearly understand how the 5010 is going to be generated by the clearinghouse. For clearinghouses that are taking your 5010 claims and taking your 4010 claims and turning them into 5010 claims, make sure you clearly understand what blanks they're filling in and how they may be moving information around to verify that they're not going to be making any representations that may be inappropriate or may not be in sync with what you're sending out and what your expectations are. The other thing I would do is I would check with key payers. So contact your key payers and see what their 5010 readiness issues are, what they're expecting from their current users. And by the way, some of these things may occur after January 1st, 2012. You may not see all the changes occur right away. They may say, this is our expectation on January 1st, this is our expectation in June, this is our expectation in July. And then understand what those payer requirements are going to be for the 5010 format in relation to your own situation. The other thing is that you're going to want to implement the 5010 practice management system version of the product that you're using. We talked about you may have some data conversion issues inside the product itself. You may have to implement, actually bring the system over. You're going to have to schedule it accordingly. There may be some other changes to the practice management system that may require some process needs to be run against your existing data. All of those changes can take time, and you want to make sure that you stage it correctly so you can generate those 5010s in time for 12/31/2011. You also may need to consider how your procedures are going to be affected by the 5010. We talked before about a number of issues that may have effects on you. We talked about the 9-digit zip code, which is going to depend on whether your payers want that or not. Also, we are going to have to go and train staff on not only the modified procedures, but any changes that they may be seeing to their user interface or additional items that may be relevant. We talked briefly about the release of information, which basically is the acknowledgement or the consent to your notice of privacy practices under the HIPAA privacy standards. Maybe we're now going to need to take a closer look at making sure that that information is correctly updated in the system. And then you also want to make sure that we monitor our initial 5010 submissions. Just to make sure that we had all the information correct in our system that was being generated into that claim, you're just going to want to be a little bit more closely watching how your 5010 claims are going through your clearinghouse as well as going directly to your payers on those initial submissions from your system. And, of course, if you run into some problems, you may need to backtrack a little bit, take a look at what the problem was, refine your procedures, and then go back and train your staff. Excuse me. Okay, sorry about that. So what is your readiness modified sheet? Monitor that initial 5010 installation submissions to make sure that that's covered. And I'm sorry for for fumbling with those slides. Thank you very much.
Thank you, Ron. Let me kind of get in here and move ahead. Just wanted to take one quick second here before we turn it over to Betsy to cover the ICD-10. Since Ron was just talking about ANSI 5010-enabled practice management systems and making sure you're up to date on an ANSI 5010-enabled practice management release, I just wanted to address if you're a McKesson Physician Practice Solutions customer today, the versions of our releases that are ANSI 5010-enabled, the Metasoft version V17, LITEC 2011, Practice Partner version 952, which will be out within the month, and then Horizon Practice Plus 12.5. So if you are a current McKesson Physician Practice Solution customer and you're currently not currently running one of these releases, you'd want to reach out to your sales representative or account manager, whether that's a local value-added reseller or with McKesson directly. Just want to make sure that all of our customers are up to date on the ANSI 5010-enabled release so you don't experience any pushback with claim submissions come the beginning of the year. And then again, as I stated earlier, we will post an email mailbox at the end of the webinar. It will be practicepartnerinfo@mckesson.com. If you do have any product-related questions, whether it's on Metasoft, LITEC, Practice Partner, or Horizon Practice Plus, you can always shoot an email there, excuse me, and we'll make sure that the appropriate individual gets your question and is answered. But with that, I will pass it over to Betsy Nicoletti here, and she will start to talk about ICD-10.
Thank you very much. If HIPAA was the Full Employment Act for lawyers and compliance was the Full Employment Act for consultants, then ICD-10 is going to be the Full Employment Act for coders when we implement that in 2 short years. So as I like to say, if any of you have unemployed children, tell them to go into diagnosis coding. How do we feel about this? We wish we could say this. I'm sorry, the doctor no longer makes diagnoses. But of course, we're going to continue to make diagnoses and code for them. And our response, maybe we have anxiety disorder, situational type phobia. I want to know, where are the ICD-10 codes for cheerful, relaxed, confident, knowledgeable, which is, of course, how we're all going to be by the time October of 2013 comes out. I hear this sometimes. Maybe they'll just postpone it again, or maybe I can retire before ICD-10. Well, I don't know if you can retire, but I don't think it's likely that they're going to postpone the conversion from ICD-9 to ICD-10. There's been commitment through this through both Republican and Democratic administrations. Sometimes people ask me, is this part of health care reform? And I have to say no. This was a Bush-era initiative, and the Obama administration has continued their commitment for it. So we're going to submit claims for services provided October 1st and later, 2013, with ICD-10 codes, and we can't start using them ahead of time. There's no grace period. So even if you go on vacation September 30th, 2013, in the hopes that you won't be there for it, any claims that are submitted for date of service September 30th and before are going to need ICD-9, and claims for October 1st, 2013 and forward are going to need ICD-10. And the one piece of advice that I would give about that might be the same advice that we have about the conversion to 5010. These conversions don't always go smoothly, and it would be helpful to have some cash or a line of credit on hand. And particularly when the change for 5010, for example, is coming January 1st, you know we're going to hit patient deductibles, and our collections can go down in January, February anyway. And even if we're perfectly ready for these conversions, maybe one of our payers, maybe one of our major payers won't be, so we want to make sure to have a little bit of a cushion there in terms of cash. I hear this question a lot. If I learn ICD-10 now, won't I just forget it all by 2013? And I think this is a real question. We don't want to all learn ICD-10 in October of 2011 and then not use it for the next 2 years, or we will have forgotten it. You know, if you're in a large organization, you already have a team set up. How much money is being spent on these teams, I can't even begin to imagine, but you're already working on your implementation. If you're in a smaller practice, you want to wait until closer to the time. But remember that everybody wants to get trained as close to October 2013 as possible so they don't forget, and that classes may fill up. So you don't want to wait until the last minute to sign up if you think you're going to need a class in order to learn ICD-10. If you're like me, I don't have a clinical background, I'm going to take an anatomy and physiology course because for those of us who code generally in diagnosis coding, we're going to need to know more clinically about many areas. If you only code for otolaryngology and you've been doing it a long time and you really understand the disease processes and the conditions that you treat in your office, that may not be so much of an issue for you. But an important piece of advice is to buy the book. When you buy the book, you'll see it still is in draft form, but we're going to buy it anyways. It looks very familiar. It has that alphabetic list of conditions and symptoms in the front, which sends you to the tabular list of diagnosis codes. In the front of the book, there are general instructions. They're going to look familiar to you. Many of them will mirror the general instructions for ICD-9. There are in ICD-10 chapter-specific instructions which take precedent over the general instructions in the front of the book. That's one of the things that it tells you in the front, in the start of those instructions. So why do I want you to buy the book now, even though you're not going to begin to code from it till 2013? It will be good to practice and to attempt to code the most common services that you're performing. And if you're having trouble coding them, then to ask yourself the question, is it because I don't have the clinical knowledge, or is it because the documentation is not specific enough for me? And I'll talk a little bit about some of those increased needs for specificity that you've all heard about. Now, our friends at Medicare did develop some general equivalence mappings, or a crosswalk, between ICD-9 and ICD-10, and it goes in both directions. You can look at that at their website, and that the specific address is in the middle of the page of this slide. There's not a one-to-one match between ICD-9 and ICD-10, so you might find that there are no matches for the code that you have, or that there are 50 codes that match. So you can't really use it in place of coding using the ICD-10 book. These gems, this crosswalk was developed for policymakers for coverage determinations, edits, trend data. It was not; they were not developed to help us code or to be the equivalent of coding. What does ICD-10? What do they look like? They are 3 to 7-digit codes. Don't we like that? Whereas now we have 3 to 5. The first code is alphabetic. Then there are two numbers and then a period. And then that could be the end of the code, or you could have 4 more codes afterwards. The alphabetic codes are case insensitive, so it doesn't matter if you use upper or lower cases. One of the major changes is that the very front of the book, when you read the general instructions, it tells you that chapter-specific guidelines take precedence over the general guidelines. So one of the places where you find that is in the maternity care chapter. So I like to say, mothers first. Sorry for all you fathers, but mothers first. But remember that. That's one of the key changes in ICD-10 that you're going to remember. The chapter-specific guidelines take precedence, and you can remember that by mothers first. There's also a placeholder for some of the diagnosis codes. So let's say you have a diagnosis code that has 7 digits, but there is no 6th digit because that 6th digit means something for that code in that section of the ICD-10 book. You're going to put an X there. But don't worry about that. When I saw that, I thought, I'll never, ever be able to do diagnosis coding again. When there is a placeholder code, it is listed in the complete code in the ICD-10 book. You don't have to remember it. You just have to notice that it's there and use it when it's there. ICD-10 is a whopper. So in ICD-9, we had 14,000 diagnosis codes. This draft edition of ICD-10 has 69,000. Now, take a look here. I have procedure codes, and notice that in parentheses it says for hospitals, not physicians. We are not giving up on CPT. I'm going to say that again. Physician offices are going to continue to use CPT codes to report the services they provide. We're not going to ICD-10 diagnosis codes, just like we don't use we're not going to ICD-10 procedure codes, just like we don't use ICD-9 procedure codes, but hospitals do. And for hospitals, I think this is going to be a really difficult transition because they're going from 3,800 procedure codes to 71,000 procedure codes, and I think that's going to be a challenge for them. So just to repeat, physicians are going to continue to use CPT codes to report the service they perform, but they're going to use ICD-10 codes for the diagnosis for why they performed the service. Each chapter in ICD-10 is divided into blocks. So if we're looking at the infectious disease chapter, for example, it'll have viruses and spirochetes and bacteria and fungus and all sorts of cheerful things, but they're divided into blocks, and those are listed at the front of each chapter. And those blocks give you a very specific and clear third way to help you find that code. So the first way we would find an ICD-9 code, we look in the alphabetic index, and that sends us to our tabular index. The second way, we might have electronic search, and the code would come up. And the third way would be that you know where that diagnosis fits within the block from a clinical perspective. So obviously that's going to help those of you who have clinical backgrounds more than some of the rest of us. But when you look at those blocks, they actually make sense, and you can see where you might find the diagnosis code that you're looking for. It's longer than ICD-9. We still have an indented format. Post-operative complications have been moved into the body system chapters. So if you have, we hope we don't have any post-operative complications, but if you have a post-operative complication from an eye surgery, it's in the chapter with the eye surgeries, the diagnosis is. And if it's an orthopedic surgery and you have a complication from that, you're going to look in the complications section of the orthopedic, of the bone diagnosis codes. Injuries are going to hurt. So this is the second thing I want you to remember about ICD-10. The injury codes are expanded so that the fifth character defines the type of injury, the sixth, the laterality. I know you've all heard that before. We're going to really need to know whether it's right or left. And the seventh digit in the injury codes sections define the encounter, initial, subsequent, or after effects. And the seventh digit of an ICD-10 code can mean different things in different chapters. So in some sections, the seventh digit is the Glasgow Coma Scale. In the maternity section, it's the fetus number. And in injury codes, it's whether it's an initial, subsequent, or long-term after effect. Here's the example of that seventh character, where we have A for the initial encounter, D for a subsequent encounter, and S for long-term sequelae. Now, that doesn't mean that these A, D, and S's are valid on every single code. So you're going to need to know by looking in the book or by a good search function whether the A, D, or S are applicable to that diagnosis code. Now, here's an example of an I code where the diagnosis shows whether it's the right eye, left eye, bilateral, or here, look, we have an unspecified I code there, and whether the condition is stable or unstable. So no longer could our physician simply scribble the word keratoconus down on the encounter form and have us go and select the right code. We would need to know if it's the right eye, left eye, bilateral, and whether the condition is stable or unstable. I often get asked at this point, well, if the diagnosis code shows whether the patient's condition is bilateral or not, do I still need the 50 modifier on my CPT code? And the answer is yes, you do. Because the payer is still going to pay you based on the CPT code and the modifiers on the CPT code. The diagnosis code establishes the medical necessity and sometimes is the source of a coding denial or a service denial. But you still will need the 50 modifier even if your diagnosis code is defined as bilateral. Okay, what else do we have in ICD-10? There are some new symbols, and just like all the other coding books we have, these are listed at the bottom of the page. A colored dot tells you that you need an additional digit when you're in the tabular section of the book. If you're in the alphabetic index, a dash after the code tells you that you need an additional digit. Unspecified codes have squares in front of them. And just like today, you can use an unspecified diagnosis code. Of course, we don't like unspecified diagnosis codes, but many of us submit them. They're sometimes on our cheat sheets, and they may still be valid as primary diagnoses. I would expect that payers are going to require more specificity and that we'll see denials if our diagnosis codes are not specific. An unacceptable first-line diagnosis code is indicated by a black dot, and that tells you you've got to go find the underlying diagnosis code. Don't give me this symptom as the diagnosis code. Some things, of course, are obvious. If you see written in the code, in the book, use an additional code, then that directs you to go to the etiology. If it says code first, then you're going to go and code the underlying problem rather than the symptom. There are notes which the developers of ICD-10 have written in there, and they're, of course, just some informational notes. Sometimes I get asked, where can I find an ICD-10 book? I bought mine right off Amazon. All of the major coding suppliers are selling them. So if you usually buy from, your favorite, wherever you get your ICD-9 books and your CPT codes now, you can buy an ICD-10 book. Or you can go online to Amazon and buy one from there. So if you're looking for a book, it's it's easy to find. Code, if applicable, tells you that you're going to go to another condition and find that. And here's the third important truth about ICD-9. So our first truth, mothers first, that is, chapter guidelines take precedent over general guidelines. Injuries are going to hurt. That is, we're going to need more specificity when we're coding injuries. And the third major thing, sequencing is going to be more difficult than coding. There are going to be some conditions that will require 2 or 3 codes, and sequencing them according to ICD-10 rules will be more complex. Now, I cannot tell you today that the payers are going to deny them if they're sequenced in the wrong order. Those of you who are close to remittance advice know that sometimes the payers don't read a diagnosis code in the second position, even though it's right there in front of them. I cannot promise you what they'll do about that for ICD-10. All right, what does the word with mean? It means exactly that. It means with involvement of another organ system, as you can see in this example. But the word and means and or. So interoperative hemorrhage and hematoma really means hemorrhage and or hematoma. Doesn't have to have them both in order for you to code that I-97.4. What is the meaning of the word excludes? Now really, besides politicians, does anybody besides coders parse their words so clearly and finely here? Excludes one means not coded here. These codes should never be assigned together. So we have sleep apnea, G37.3, and right underneath the code it says to you, here's a little note, characterized by episodes in which breathing stops during sleep. Code also any underlying condition. And then we have an excludes one note. It excludes apnea not otherwise specified, which is this R code. It excludes sleep apnea of the newborn, that P code. So it would be incorrect to code P28.3 along with G37.3 because that is excludes one. They're never coded together. Now, excludes 2 means it's not included here. This isn't the right code for you, but if the patient has both conditions, you can assign both. So say a patient has insomnia, G47.0, but they also have insomnia due to a mental disorder, F51.01. You could assign both of those codes if the patient had both conditions. All right, some things are very familiar to us in ICD-10. Code also just tells you we're going to go and look at that. Punctuation remains the same. That hasn't changed. And we still have both the alphabetic and the tabular index to select our codes. I mentioned we had this placeholder code, this X. It holds a space for future expansion. I'm glad they're not saying maybe we might not expand to 8, 9, 10, and 12 codes. I'm glad they're stopping at 6, at least for now. So this future expansion might occur in the 5th or the 6th digit. And here we have an adverse effect of tetracyclines, and there is no 5th digit for this code. So the code is T36.4, the placeholder code X5. It has a large blue dot before the code if you were looking at the actual book, which tells you that a 7th character was required. And for this code, the A, D, and S 7th character. This is the initial encounter for an A, a subsequent encounter for use the D, or a long-term after effect, we would use the S. Going from the ridiculous to the sublime here, you want to be careful about fonts in your training materials and also in any charge entry. Now, if you're using an electronic health record, your physician or nurse practitioner, physician's assistant is assigning the CPT code. They're pulling it off a list in your system, and then they're pulling their diagnosis code off a list. They're not entering it. They're searching for it and selecting it. But if you have an out-of-office service where the physician brings back a piece of paper and says, look, I did this cataract surgery, and here was the diagnosis, cataract. I guess that's repetitive, but that's what a lot of the information on claim forms is. Then when you're doing charge entry, you need to be careful about data entry, and am I using an I, a number 1, a 0, or the letter O, because it looks different. The L's can also be confusing. A capital L and the letter 1 can be confusing depending on the font. So you want to be careful about that when you're doing your training materials and in charge entry. The codes, again, are not case-specific. Capital and small letters carry the same meaning, and I'm just restating here, we want to be very careful about the training materials we use so that we don't confuse a 0 and the letter O, because if instead of putting in the letter O for your diagnosis codes that start with the letter O, you put in the number 0, all of those claims would be denied as having an invalid ICD-10 code. We don't want that. Some of these other issues, if you look at this, go down this list, you would say, wait, this is just like ICD-9, because if you're going to correctly code a neoplasm and not just use 174.9 and 150.9, all the non-specific codes, you do need increased information. So if we get in the habit of that now for ICD-9, the transition to ICD-10 is going to be easier. Injuries are going to be difficult. When we're coding strokes, you'll need to know whether it's dominant or non-dominant. Some conditions will require us to know whether it's a primary condition or a secondary condition. Pain control actually hasn't changed. If you look at the instructions for ICD-9, we're instructed to use pain control as the first diagnosis if that is the primary reason for the visit. That stays the same. The congestive heart failure codes are more specific in ICD-9 than they were 2 years ago when we were just allowed to use 428. So you're going to continue to need to know the type of congestive heart failure the patient has. MI, continue to know the location and whether it's a non-STEMI or a STEMI. And laterality and severity are sometimes going to be needed when we're coding ICD-10. What are we going to do now? What you do really varies in large part by the size of your practice. If you're a small practice, all you want to do right now is be on the latest version of your software and buy an ICD-10 book, and then begin to look at your most common codes. If you're a large practice and you're going to need to train 8 coders, 10 physicians, 5 nurse practitioners, if you have a large group, then you want to have a timeline about when you're going to train your own internal trainer and when your trainer is going to begin to train the other people in your practice. So you're going to need a budget for this, both for upgrades, for your software, and for training of your group. Training's available, of course. The commercial vendors are happy to help. I don't know how many emails a month I get about getting ready for ICD-10. I don't know about you, but my eyes have glazed over by them. All of the coding societies are offering training. The physician specialty societies, I believe, will probably come on board. And if you're a specialty society, that may be the best training for you. I do know that the APC, anyone who's a CPC, is going to have to retake a test for ICD-10. I assume AHIMA is going to require that as well. And there are a series of PowerPoint and audio presentations on Codepedia that are available for you to look at for free. So there will be training available for you. I'm going to end with just these 3 notes. Sequencing is going to be more difficult than coding. Chapters, instructions take precedent over general, that is mothers first, and injuries are going to hurt. So I'm going to turn this program back over to you, Lisa, if you want to have some words before we go into our question and answer period.
Great. Thank you, Betsy. We will definitely open it up for questions now. I just wanted to mention first I see a question in the queue. Betsy, I think this one is for you on ICD-10. A gentleman was asking if there's extensive changes in ICD-10 for mental health diagnoses. Not sure if that pertains to the book where you were talking about the blocks.
So when you look at the mental health diagnoses, I don't think you're going to have a lot of trouble with the changes. It's a short section. I'm going to try and find the chapter here really quickly. You're still going to be using ICD-10 on your claim forms, just like you do now, use ICD-9, but you're going to internally be using DSM, whatever you're up to, DSM-5. So the beginning sections, it's Chapter 5. All the mental and behavioral disorders start with an F, and the blocks are pretty straightforward. Mood disorders, schizophrenia, anxiety, behavioral symptoms. It's a pretty short chapter, and if you can do diagnosis coding for mental disorders now, I don't think you're going to have trouble with ICD-10.
Okay. And moderator, I think we could open for any questions over the phone.
Thank you. To ask a question at this time, please press *1, then record your first and last name when prompted. Once the recording plays into the conference, your line is open. You may proceed with your question. If you are using a speakerphone today, please unmute your phone to allow your voice to be recorded. Again, please press *1 now if you would like to ask a question. We'll pause for a brief moment to assemble the queue.
Barbara,
Please go ahead.
yes, I just wanted to know how this is going to affect ambulatory surgical centers.
What's this?
The ICD-10s and CPT codes.
I believe that in the ambulatory surgery centers, you're going to continue to use CPT codes for your procedures and ICD-10 codes for your diagnoses.
Are we going to be have to learn a whole bunch just like the hospitals?
I don't think that ambulatory surgery centers are going to use ICD-10 procedure codes.
Okay. Thank you.
You're welcome.
We'll move to our next question. Please go
Peter
ahead.
Gensheimer. Hello? Hello?
Go ahead.
Yes, a very specific question about the zip code issue. If I understood the gentleman correctly, he was stating that zip codes under ANSI 5010 would no longer be required unless specifically required by a given carrier, and when that occurred, it would be the 9-digit zip code. And I was just curious as to whether or not there's any feedback yet from Medicare as to what you think they might be requiring, no zip code or 9 digits, and if so, where would they require that?
Well, the bottom line to that is, well, first off, remember, as a biller, it's not that big a deal, but as a biller, you have to have the 9-digit zip code in the billing information. That's required. At the patient level, the address, the city-state zip is no longer required. It's situational. But I haven't seen Medicare commenting on that yet.
So, with respect
but that can be payer specific. A specific payer could say, we want that, and they're going to be checking for the 9-digit zip code. It's going to be how the payers interpret it.
So it is still possible that Medicare could comment that they
correct anything that's
for the patient.
Correct. Anything that's situational, it's basically moved from a mandatory requirement to a situational. And situational means that an individual payer can decide to use that segment, and then they can decide how they might require it.
Okay. Thank you.
I hope for all of us that Medicare won't require it.
We'll move on to our next question.
Patty Fabian? Yes, am I on?
Yes, you are.
Thank you. Will there be new paper HCFA forms for the new 5010 starting January 1st for those vendors that don't accept electronic filings and for some secondary that don't accept electronic, or do we use the same HCFA 5010 form we have, or HCFA form we have now?
Well, they have to come up with a new 1500 because at a minimum you can have 4 new diagnosis codes in there. But I don't believe the format has been released yet.
Okay, thank you.
We'll move on and take our next question.
Melody Cowdery. Hello. I was wondering if there is a recommended resource that we could purchase for to show us the 5010 layout and specifics related to 5010.
I mean, I suggest the first thing you do is go to your clearinghouse, ask them for their 5010 notes, and take a look at it that way. The actual format, comparing the 4010 to the 5010, is a 60, 70-page document. So I don't know if you want to get into the nitty-gritty of those things. A number of the changes that are in the 5010 are things that are going to be handled by your vendor. So I would concentrate on those areas that are relevant to your payer and areas that are relevant to your clearinghouse.
Okay, thank you.
We'll move on and take our next question.
Angela Smith.
Yes. My question is, how much, if there's a formula for how much cash or line of credit would you suggest?
Well, I would suggest that you have 45 to 60 days worth of cash. Ron, do you have a feeling about that? A suggestion?
I think that's a good plan. We don't know if there will be any effect, but the chances are, if we look at previous history, there will be a delay. Don't be surprised if there is a delay.
Okay, and that's hard for 5010 because if you're in a private practice, that's the time when the physicians want to take their bonus and want to have decrease their taxes by, the accountants will have a recommendation for them. But if they don't have cash, then I would certainly have a line of credit that would cover 2 months of expenses.
That's a really good point because a lot of those checks are going to be written at the end of the calendar year, and that means you basically depleted your cash position moving into 2012. So there's a real cash flow exercise to think about. That's very different than when we run into delays at the end of the federal fiscal year that don't really affect our cash within the actual calendar year. That's many of our tax years. But that's a great point. You might want to think about that. The other thing I would do is keep your ear to the ground about what's going on with 5010 adoption. Specifically, if when you start seeing the 5010s dropping, are they getting to where they need to be? The real sad thing would be if your 5010s are being rejected because of something you're doing, because perhaps the training wasn't complete, or we haven't gotten all the information we need to get in, or we didn't know what our key payers wanted, and that would be the real shame. The fact of a particular payer not being able to pay you because of something on their end is not anything you can control.
All right. Thank you.
Once again, just a reminder, everyone, it is *1 if you have a question or comment. If you find your question has been answered, you may remove yourself from the queue by pressing *2. And we'll move on and take our next question.
Susan Berber.
And Susan, your line is open.
Oh, my question was already answered. Sorry about that.
That's okay, thank you. And we'll move on and take our next question.
Cindy Strasser. Hi, my question is regarding the ICD-10 coding. We're a therapy group, and we provide physical therapy, occupational therapy, and speech therapy. And are there going to be huge changes? Is this going to be a difficult transition for us, or do you anticipate it'll be an easy transition?
I think that you will have a difficult transition because some of what you're treating are injuries, and the injuries are going to be difficult. And I would expect that you're using diagnosis codes from a number of different sections of the book. So you're going to continue to use your same CPT codes, but your diagnosis coding is going to need to get more specific.
Thank you.
I know you didn't ask a question about 5010, but one thing I do want to kick in there is you might want to take a look at the 5010 for your PT and OT because of the some of the disability information that is now reportable in the 5010 format.
Okay, thank you.
We'll move on to take our next question.
Melissa Benfield. Yes, what I had a question about is I would like to know, I know you mentioned that the general release date for Practice Partners 952, which we've been anxiously waiting on our practice end so that we can get started with numerous changes. When do you expect the release date to be for 952?
So it's Lisa here with McKesson. 952 for Practice Partner will be released within the month, so within the month of August.
So by August
yeah,
30th?
Yeah, well, yeah, by then for sure, but within the month.
Okay, great. Thank you.
And we'll move on and take our next question. Please go ahead.
Terry Lynn. Hi, I just had a question about the ICD-10 and well child care or preventive medicine type. Are these going to be specific diagnosis like 3-year-old in for well child care? Do you see what I'm saying? We put the diagnosis for the immunizations, but you're stating they have to be very specific. So how's that going to work?
Yeah, no, the examination codes are in the back. I can't remember now if they're V, W, Y. I think they're Y codes now. But they're a set of examination codes, and they are not age specific.
Okay. All right, thank you.
You're welcome.
We'll take our next question from
Karen Green. Hello?
Go ahead.
Hi. I'm in a residential care facility, and we have people with mental issues, but they also have health issues. Will the codes from the hospitals be transferable? Say if they go into the hospital for an emergency care and come back to the facility, would those codes be transferable to our system for the ICD-9? I mean ICD-10.
So nothing has changed about that.
Okay.
If you so that patient comes back, you would use the reason that you're seeing the patient that day. You wouldn't use the reason the hospital saw the patient.
When they come back in to do an assessment,
so
we would have to code that through the reason that they were in there. Normally now we code the reason that they were in the hospital when they return. Do you know what I mean? It asks for that. It asks for medication changes, all that type of stuff.
So it would just depend on what you documented. So if you document, she has pneumonia and she's on day 4 of the treatment for that, and she's been short of breath, but it's not so bad, and she's using a nebulizer, then you could use the pneumonia. But if the patient no longer has that condition, then using either ICD-9 or ICD-10 rules, you would not code that condition. And you code for conditions that you're addressing that day or underlying conditions that affect today's treatment.
Even on our 60-day assessments? because these are general health concerns for these people 365 days, not just 1 or 2
Now, you're
years.
asking a really specific question
Okay.
that's out of the realm of what I'm going to talk about today or what I have talked about today. So I would suggest you get out your ICD-9 book and read the general coding guidelines at the start and use those guidelines to select your codes.
To select my codes in the 10 book, huh?
Mm-hmm.
Okay. All right. Thank you.
You're welcome.
We'll move on to the next caller.
Lupita.
Hi.
Go ahead.
Hi, my question is regarding the claim notes and where you would write, where you would send a note or a medication list a claim, for instance, to Medicare. Will that remain the same, or do we have to take that up with our vendor?
You have to take that up with your vendor. The point about the claim notes is that there is a way of sending claim notes electronically.
Right.
That you can actually put a note in the claim itself and send it. That doesn't necessarily mean that if the vendor says you have to submit supporting information, this is not like sending an office note. This might more like be sending an explanatory note or supplemental information that would be, fit in a relatively small area. But the actual notes to support the claim itself would be sent according to the way they currently accept it.
Okay. Thank you.
We'll move on to the next caller.
Melissa Keller. Yes, hi. I'm asking regarding ambulance transportation. We go by the ICD-9 codes now. Will we have to get even more specific if you're transporting somebody for like a right leg fracture and so on? And
yes. You won't be able to find, there are some non-specific codes in the ICD-10 book, but I think you're going to have trouble in the long run getting paid with those. So, yes, if there's a right leg versus a left leg injury, and you may not know it's a fracture when you're transporting, so you may be using a symptom code,
right.
But most of those are more specific.
And with the 5010, because we're going to have a new CMS 1500 form, we're going to have to put more detailed documentation. Is that correct?
We'll have to, if they require the ICD-10 code and they require that level of specificity, then it's just going to be accommodated in the HCFA 1500 or the 5010 837.
Okay.
So either way, on any situation like that, you basically have to go back to the payer and see what they're going by and what requirements they're going to have. And that's why when we were talking earlier, we talked that when you're sending in your initial 5010s in early January 2012, you really want to monitor how successful you are because you want to catch any problems right away. And the other corollary to that is you have to be careful about what's going out of your system. When you put in a new practice management system version and it has a higher level of edits or better tracking of problems and things like that, you really have to check your edits and your errors to make sure that you're clearing things up so the claims can be dropped. Because things that obviously, if it's not getting out of your practice management system, it's not even going to get to the claim. We've had situations where people are not checking their practice management systems closely enough, and then they find out later that a bunch of claims weren't dropped. So all those things need to be checked and verified and just monitored more closely. And I would suggest the same thing happens when you move into the ICD-10 arena. Just keep much closer monitoring of the claims that are going out and keep closer monitoring of what's being trapped at the clearinghouse level.
And just a reminder to our audience, it is star one if you have a question or a comment at this time. You may remove yourself from the queue if your question has been answered by pressing star two. We'll move on and take our next question.
Christine Pavlik. Hello. My question is for Betsy. I have a question regarding the certified professional coding. If I'm a practice manager in a small IDTF, you recommended taking an anatomy and physiology course. I'm wondering, with the CPC course, if I took something like that now, would the training include the ICD-10, or would I have to take 2 exams?
I don't know the answer to that. You have to check with the AAPC and see when they're including ICD-10 in their coursework and in the testing.
Okay. Because at this point, there's no specific date set for testing or recertifying coders for the ICD-10, is there?
You know, I know that all of us who have our CPCs are going to have to take an ICD-10 test. I know we're going to have a year to do that, so I'm just not sure when they're actually going to start that, and if it's going to be in person or online. I'm not sure how they're doing that yet.
Okay. All right. Well, thank you.
You're welcome.
We'll move to the next caller in the queue. Caller, please state your name. And caller, we're unable to hear you. Please release your mute function or pick up your handset. And caller, your line is open. And hearing no response, we'll move to our next caller. Please go ahead.
Pam Dodro. Hello. Do you anticipate any cash flow problem resulting from the 5010 implementation or just from the ICD-10?
The cash flow problem from the 5010 implementation could occur in a couple of different areas. Number one, if you're having trouble submitting claims from your end as you're moving into the 5010 environment, and that's why we were making very strong recommendations. Number one, that you adopt the 5010 version of your practice management system. Number two, that you go through the process of looking at your clearinghouse as well as your key payers to determine if there's any changes you have to make to accommodate their needs. And number three is to make sure that you do adequate training of your staff on any changes that may be necessitated by the 5010. So I feel like if you go through that process, then at least the problem's not going to be on your end. The issue with the cash flow also has to consider the problem on the other end, which is the payers. If the payers aren't ready, if the payers have problems processing claims, if the clearinghouse has problems and things like that. So there is a possibility, and we've seen this happen before in our last similar experience with this, where there were some payers that had some problems processing these claims, and when they have the problems processing the claims, unfortunately the person that gets hurt is your practice, and therefore you want to monitor this. It's very prudent, as Betsy suggested, to have some money lined up to deal with the possibility of having a cash flow issue. And then the bottom line is to make sure that everything's okay on your end, and then just monitor what's going on up at your payers. In other words, when you're submitting claims on a daily basis and everything's going well on your end and you're not hearing anything back from the clearinghouse, it might be a good idea to go in and check on claim status up at the clearinghouse level to make sure that everything, up at the payer level, pick a couple of key payers and just check some of your claims to make sure that their processing of claims hasn't gotten delayed.
Thank you.
We'll move on and take our next question from
Susan Borger. Hi. Can you hear me?
Yes.
Yes, we can.
Okay. We're an endocrinology practice, and from your knowledge of the ICD-10 codes, would you say that endocrinology would be highly affected, little affected?
Well, you've got the diabetes codes in there, and I think, let me just look at the, all the endocrines are in Chapter 4, and it's a reasonably short Chapter 2. How often are you coding for services outside of those that are just endocrine?
Not very often.
Not often. Then you're probably not going to have a lot of trouble. Thyroid, diabetes, pancreas, malnutrition, other nutritional deficiencies, metabolic disorders, overweight. it would be worth it. I do recommend get the book sooner rather than later, and then look at the secondary diagnoses that your clinician is using. I think you're going to find that the primary diagnoses are going to be easy for you, but if there are secondary diagnoses, neoplasms, or other conditions, you want to just take a look at those.
Thank you.
You're welcome.
We'll move on and take our next question.
Cindy Bradley. Hello. I'm an office manager of a small PT clinic and trying to get the most bang for our buck. Is there any recommendations in regards to where to take classes for the 5010 and the ICD-10?
Ron, why don't you start with 5010?
Okay. I think everybody needs to be careful about something. If you get into the 5010, as in the 837-5010 format, you may be doing a lot of work and a lot of effort in an area that you perhaps aren't really going to need that information. The fact of the matter is your practice management system is really the one that creates the 5010. It's the one that formats it. It's the one that puts it together. You really don't need to know about all these segments and all this other information, especially for small practice. So therefore, I think that a better use of your time is going in and checking with your clearinghouse, who is going to give you a much more concise key areas to look at. I think it's much more better use of your time to get in contact with your payers. They're going to give you a much more concise, limited list of issues to worry about. And I think if you go to those two sources and basically say, what should I worry about, now you sit down with your practice management system and say, okay, well, how do I deal with patient-specific ID numbers, or how do I deal with this insurance company wants me to, especially in the context of your PT clinic, this insurance company wants me to be providing disability information. And that gives you a much stronger focus than dealing with the general attributes and general capabilities of the 5010 format.
Okay.
When you get a copy of the slides, which will be emailed to all participants following the webinar, you'll see that on the second to the last slide I had some options for where you could get training. So there's the free ICD-10 PowerPoints on Codepedia. And then I would look at the two coding societies and compare those. AHIMA has always been a little more focused on hospitals and AAPC more focused on physician offices, but that's a broad statement, and within each you could find coding related to physician practices. And then literally every single commercial vendor wants to sell this to you, Ingenix, HC Pro. So, you just have to look and see who's going to be near you, if you can do it online, and what the prices are going to be. I have not seen yet specialty-specific training coming from the physician specialty societies. And if you are in a specialty, you might wait just a little bit and see if they're going to do that, or send an email to each of their coding and practice management departments and see, because that would be really good training if you were a specialist.
Along those lines, you also contact your clearinghouse and see what training they might offer about specific issues associated with their clearinghouse, or similar to payers. Sometimes payers and sometimes clearinghouses have more targeted information about the 5010.
Okay. Thank you.
We'll take our next question in the queue. Caller, please go ahead. Please state your name, caller. If you're using a speakerphone, could you release the mute function or pick up the handset? We're unable to hear you. And your line is open, caller. Please go ahead. And hearing no response, we'll take our next question. Please go ahead, caller. State your name.
Hello?
Hi, your line is open.
Hi, my name is Patrick. Can you hear me?
Yes.
Okay, I had a few questions about I understand for the new 5010, primary payers will be forwarding claims automatically to the secondary payer. Is that correct?
You have to check with your primary payers, and typically, technically, the answer to the question is any payer can forward to any other payer. That does not necessarily mean that every payer is forwarding to every other payer. So you have to check specifically with your payer and see who are the, and you can't do this with every payer. You check with your key payers. Are you forwarding the secondary claim, just like a Medicare crossover? Are you forwarding? If you're not forwarding, then you're going to have to take care of it.
Oh, okay.
That's going to be payer specific.
Oh, okay. So they will not every payer will not automatically forward.
Not necessarily. Not necessarily. It's a great idea, but that's not necessarily going to happen.
Okay.
We're rooting for you, Patrick.
All right. Thank you. That's all.
We'll move on and take our next question from
Alyssa. I was just wondering if they've already published the new version, or what company for the book for ICD-10 would I go for? I have the ICD-9 CM, but I don't know. Do they already have the book out? I haven't seen
Yep, the book is out. It's a draft version because we're not using ICD-10 yet, so you're going to need an updated copy when 2013 comes along. Okay. As we get closer to 2013, they're going to make limited changes to both ICD-9 and ICD-10 so that we get the libraries and firmed up and we don't have to learn and relearn. But I went on Amazon and bought a copy of ICD-10. I guess mine is published by Elsevier, but anyone can publish an ICD-10 book. Unlike CPT, CPT is copyrighted, of course, so only the AMA can allow you to publish those codes. You have to get permission. ICD-10 is not copyrighted, and you can find ICD-10 websites where you can look up codes there, or you can buy a book from any commercial vendor from whom you've bought your ICD-9 book. I bought mine from Amazon.
Okay, great. Thank you.
You're welcome.
And we'll move and take our next question.
Cindy? Hi, I have two questions. The first one is, will the 5010 change the format or the form used for submitting paper claims? And the second question is, would any of those payers accepting the paper claims automatically forward to secondary insurances, or is that only for electronic claims?
Okay. The answer to your first question is the 5010 is definitely going to change the HCFA 1500 for no other reason than we talked about a couple things related to subscriber and patients, and we also talked about the notion that the 5010 also has additional ICD-9 codes. So the HCFA 1500 does have to change. It has not been defined yet, but it has to change. The paper claims going to the secondary, it's not going to happen. And the reason it's not going to happen is because the paper claim itself doesn't allow you to indicate who the secondary payer is that's going to allow you to send that information forward. So that's not going to happen.
We do have a question from
Karen. Hello.
Hi,
Karen. Go ahead.
Hi. My question would be, now these books are a little costly, and if we got to buy one now to get acquainted with it and one after all the changes are made and they finalized it, I might have a little trouble getting that through my budget. I know that
it costs money to make money.
Yeah, that's true. Yeah, I'll have to see how they go for it. Would it be a good idea just maybe to use the link until they finalize the books, or they should have something available online to just reference it, correct?
My recommendation, buy a book. Buy a book this week.
That's the best way.
Yep.
This week?
This week.
Okay, I better hang up so I can go to the store. I appreciate it. Thank you.
All righty.
Okay.
I don't really mean this week, but buy a book soon.
I got what you're saying, yeah, because this looks like it's going to be quite a transition.
Yeah.
Yeehaw. Okay. Thank you.
We'll move on and take our next question from Debbie.
Yes,
Debbie?
my question is clarification on a comment that was made a few minutes ago. If the primary payer today is forwarding a claim electronically to the secondary payer, do I understand correctly that that may change with the 5010, or can we count on it probably going ahead and still being as it is today?
If you have a primary payer that is currently forwarding a claim to a secondary, like in a Medicare crossover situation, you pretty much can bank on the fact that they're going to continue to do that with the 5010. Remember that saves everybody lots of money. The issue is that if you have a primary payer who's not forwarding a claim to certain other insurance companies, not every insurance company is processing secondary crossover claims or tertiary crossover claims from other payers. So you just have to monitor what's going on, especially with your key payers. We ran into that problem. Just go back to think about what happened when we ran into the same problem with Medicare crossover, where Medicare crossover in some cases was sporadic. In some cases it was for certain insurance companies but not others. So you're going to see that same adoption. But it's in the insurance company's interest to do it. The nice thing about Medicare crossover is Medicare crossover, when you're submitting the secondaries, you don't have to send along the primary payment information. The primary payer already did it. Note that in the 837 claim itself, you can actually submit the primary payment information inside the claim. So as more and more payers adopt this strategy and accommodate this technology, realistically, the idea that we're printing paper claims and attaching the EOB is really going to disappear.
We are currently doing that, capturing the EOB information from the primary to send along to the secondary if they receive electronically, and I agree that that is a wonderful thing. My second question has to do with the 835 transaction set, and I'm assuming that that is also going to convert to 5010. I really didn't see anything in this presentation that indicated changes to practice management systems that would be specific to the 5010 format for the 835 transaction set. If the software is compliant for the 5010 outbound electronic claim, then is it a pretty easy assumption that it is compliant for the inbound 835 transaction set?
I would say that's a very easy assumption, and it's the 5010 family, if you will. Also note that the 835 5010 changes were not really that dramatic. We have some pretty substantial stuff on the 837, but the 835 was not substantial.
Okay. That's good news. Thank you very much.
Thank you.
And we'll move to Jennifer.
So I just want to be the timekeeper here. So I think this is going to be our last call for a question for the day.
Okay, great. My question is, we are in a chiropractic field. Do you see a lot of changes as far as the ICD-10 that we would need to study up on that?
Yes. All of the injuries are going to be difficult. And since you do a lot of those kind of services where you're taking care of people who have injuries, I think you're going to that's going to be an issue for you.
Okay.
I think you're going to see, you're one of the specialties that are going to have more changes rather than fewer.
Oh, because it has to be classified as more than just one type of injury. It has to have more specifications to that, correct?
Yes. The location codes are much more specific, and obviously you'll need to know if it's right or left, but what part of the foot, what part of the shoulder or ankle are more specific. So the injury codes in Chapter 7, in Chapter S, are going to take up many, many, many pages, and you should start sooner rather than later.
Okay. Okay, great. Thank you.
Great, thank you. I just want to thank everybody for joining today's call, and thank you to Betsy and Ron for taking the time and fielding all the questions here at the end. Again, as a reminder, we've been recording today's call, and we will be following up within a day or two, supplying the recording to all of the registrants. But again, thank you so much for joining, and we have another one this Thursday if there's other people from your practices that are interested in hearing. Thank you.
That does conclude our conference call for today, everyone. We thank you all for your participation.